Yes. Dr. Udgit, you can now come back. Yes. We start the meeting. We are live on YouTube now. Good morning, friends. Welcome back to this Saturday Club morning meeting. And today we have a very interesting topic and a very eminent speaker with us today. Dr. Udgit Thakkar is an intensivist in Baroda. He did his MBBS and MD medicine from PS Medical College, Karamsad. And then he did his IDCCM critical care from Jastrock Hospital, Mumbai. He is currently director and chief intensivist at Secure ICU and Specialty Hospital, Vadodara. He is a teacher for critical care and consultant intensivist at Parul Sevasram Hospital, Vadodara. He was ex-consultant intensivist, Bankers Group of Hospital, and ex-group in charge critical care, Sunshine Global Hospital. Few interesting thing about him: he owns the intellectual rights of telemedicine in healthcare, 23/2013, and he is bachelor in Indian music, classical music also. That is very interesting, being an intensivist and doing Indian classical music both. Faculty in various regional and national conferences, and he has to his credit various original research presentations at national and international level. So with this introduction, I request Dr. Udgit to start his talk on 10 things we commonly miss while treating sepsis. A very interesting and a very important topic for us to learn. So over to Dr. Udgit. You may speak for about 40-45 minutes, and we'll have about 10 minutes of discussion. So over to you, Dr. Udgit.
Thanks a lot, sir. Am I audible?
Yes.
Yeah. So thanks a lot, sir, for inviting me to this August audience and with this topic. I have nothing to disclose. All the data is from live experiences. All the images are from Google, and there is no conflict of interest to declare. This is what I evolved. This is what I came to know throughout my career in exclusive critical care of around 10 to 12 years. So, and there is the topic is chosen and prepared freshly. The World Sepsis Day falls in this month, that is the month of September. We are going to celebrate it on 30th September. And the theme for the this year's World Sepsis Day is prevent it, spot it, treat it, and beat it. So this is basically, we are in the right month to discuss this topic. We have to understand the burden which sepsis gives to the society. Basically, it is a significant burden to the society. Significant number of people fall sick, significant number of deaths because of sepsis are happening. And this is why we have to, and this is one important thing which is preventable. So we have to act accordingly so that we do not complicate the patient, and the mortality and morbidity of the patients are as less as we can make it. The lecture is designed in such a way that there are these 10 things are separate from each other. Actually, each topic can be taken as a separate lecture, but we are just summarizing it everything in a nutshell so that we achieve more in a less time and achieve more knowledge in a less time. So anyone joining from any time in the lecture will be able to understand from the current topic. The questions and answer can be accommodated at the end of each point also. You can anytime just stop, and it's 40 minutes is a little longer time to speak, and interaction is always welcome. There is an take-home message after each point. So only single take-home message, and we can go ahead and move ahead, and we can improve our practices as far as the sepsis management is concerned. So we'll continue with the first topic, the definition of sepsis. And this is what I mean to say, that we do miss the correct definition of sepsis. Change is the only constant thing. And unless we know how sepsis is defined, the recent guideline and academic discussions are not appropriate. The sepsis third conscious guidelines are, sepsis 3 definitions are, sepsis is defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. organ dysfunction as identified by acute change in total SOFA score more than 2 points and presence of infection. So the blame is on immunity. This is basically a revised guideline of sepsis, which evolved from the previous guideline. So in the traditional definition of sepsis, there was a category called severe sepsis. So previously, we were knowing that there is SARS. So any patient who is having tachycardia, tachypnea, we were just identifying that patient as having SARS. And the problem with that definition was that the patients were changing categories so fast. So it was basically SARS, then sepsis. SARS is no need to prove any infection. Then comes sepsis, which is the presence of infection. Then severe sepsis, and then septic shock when hypotension occurs. So they have removed the category of SARS here and the severe sepsis. So only two things remains now. This is very important for us to know. That is only sepsis. This is suspected infection. Okay, and the septic shock. Septic shock is sepsis plus hypotension, that is mean arterial blood pressure less than 65. So there is no guideline of systolic and diastolic blood pressure. It is just the mean arterial blood pressure, as well as lactate more than 2. So lactate is a definition, is a part of definition of sepsis. We must understand that SARS doesn't exist now onwards. Okay, so this is a change in the definition of sepsis, and this is how we are supposed to define sepsis now onwards. There are only two categories, only sepsis and septic shock. Yeah. Do you find anything missing in this sepsis definition? Anyone from the participant? Do you feel that something is missing? Anyone want to attempt, or should I go ahead? Sepsis always comes with one thing, and that thing is missing in this definition. It is missing because the people who define sepsis doesn't feel that it is important, obviously, because every word in that definition is important when around 70 lakhs people are dying because of sepsis in this world. And the thing which is missing is fever. There is no fever in the definition of sepsis. It is not required to have high WBC count. It is not required to have fever in the definition of sepsis. So this is what the message is, that SARS is no longer existent. Fever is an important part as far as the clinical syndrome of the sepsis is concerned, but it is not a part of definition. Sepsis can be there without fever, and sepsis can be there without leukocytosis. My second point is sepsis is an emergency. Treat it like an emergency, just like myocardial infarction or road traffic accident. It will save lives. It is as important as that. This September, we is celebrated as a sepsis month. So basically, this September is a sepsis September. There are three things which indicate sepsis. The mnemonic is time. So they have designed the mnemonic in such a way that it feels that it's an emergency and you have to act fast. T is for temperature, that is abnormal. I is for sign of infection. M for mental decline, and E for feeling extremely ill. So these four things, whenever present, you have to act fast. Okay, and diagnose sepsis. These are clinical features of sepsis, not a part of definition. Sepsis is an emergency. We have to find out the source of sepsis. There is no compromise about finding out the source of sepsis. We have to find out the source of sepsis as soon as possible. It's life-saving. Once identified, remove it like just now, not tomorrow. So whenever you feel that there is an intra-abdominal abscess, it is not a planned surgery next day morning. It is like you have to do it now in the middle of night. Next day morning, you will have a patient who is having no urine output, or a patient with abnormal PT, PTT and platelets, and then you won't be able to operate that patient. Suppose you have a patient with diabetic foot with gangrene, you have to remove it whenever you are able to identify that this gangrene is causing problems in hemodynamics as well as the problems in circulation and organ dysfunction. So you have to act as fast as we can, like we do it in other cases like stroke. With thrombolized stroke and myocardial infarction, we either go for a primary angioplasty in 90 minutes or thrombolysis in 30 minutes. The sepsis should be treated as fast as we can. So it is number one cause of deaths in hospital. It is number one cause of hospital readmission, and it is number one cause of healthcare cost. In our country, like in India, the cost is also a very, very important factor. This is also a very important point that about 50% of survivors have suffered physical and or psychological effects of sepsis. Usually we recover completely after a proper treatment from a myocardial infarction, but for sepsis, the story is different. The main important thing is that you can make a difference. It is your domain. You can make a difference. If we properly implement the sepsis management, there is 30% reduction in the hospital mortality. And that is why this lecture is. Sepsis is an emergency. It's a major cause of mortality, morbidity because the treatment is delayed. It needs lots of resources, including ventilator and dialysis, if the treatment is delayed, and it is causing long-standing disabilities and recurrent admission because the treatment is delayed. If we are on time, as fast as we can, if we identify the source of sepsis and we start treatment, the recovery is very speedy. Now we'll move over to the third point, that is diagnosis of sepsis. This is the most important part of any sepsis management, and this is even the most important part of this ongoing topic as well. Most important thing that without diagnosis, there should be no treatment. Like you cannot drive a car on the road without license. You cannot diagnose the disease. You cannot treat it. There are total 4 types of sepsis, and there are total 4 types of pathogens. The first is bacteria. The second is virus. The virus comes before fungus because we are having it more often in the era of H1N1, that is seasonal flu, that is swine flu, and the COVID. The third thing is fungus, and the fourth is parasite, which includes malaria. So bacterial, viral, fungal, and parasitic sepsis. The treatment for 4 are same. In every sepsis, the antibiotics are not needed, but to preserve antibiotics, to use it judicially, and to have that courage not to use antibiotics, what we require is a proper diagnosis. So this thing will guide. I have to complete this diagnosis of sepsis in around 4 to 5 minutes. So detailed discussions we can have in the question answer. But this is in nutshell that for bacterial infection, you can take help of a report called procalcitonin. If procalcitonin is positive, it means that the bacteria are actively multiplying and synthesizing their cell walls in your body, in the patient's body. The cultures will be of extreme help. The viruses are usually diagnosed as diagnosis of exclusion with leukopenia. All the reports except CRP are usually normal, and we can go for a polymerase chain reaction, that is RT-PCR, which is now very commonly done in the COVID era as well. And for fungus, the tests are 1,3-beta-D-glucan and galactomannan. Galactomannan is specific for Aspergillus, 1,3-beta-D-glucan is not. So we can use these 2 tests, and with combination of these, we can properly identify whether we are dealing with fungal sepsis or not. The parasites, so we have multiple tests. But the main important thing is the ceftriaxone. Fever is not a deficiency of ceftriaxone. The sepsis is not about antibiotics. Sometimes we need to give antibiotic in fungal and viral sepsis just to prevent secondary infection. That is okay. But higher antibiotics always we can keep reserved for documented cases. Procalcitonin differentiates sepsis with other diseases. That is, it will completely differentiate bacterial sepsis from the viral, fungal, and parasitic. It differentiates and it guides for the antibiotic therapy as well. CRP is often useful, but it is usually raised in all type of inflammatory condition, which includes all sepsis. But the procalcitonin is particular for bacterial sepsis. If the procalcitonin is having rising trend, like double the previous value, then you have to change the antibiotic after sending cultures. If procalcitonin is negative, you have the time to diagnose the disease. I'm not saying that you can direct strictly rely upon one single test and take decision of antibiotic, though it is absolutely recommended. But we can have some time to start up with some basic antibiotic or start with no antibiotic and diagnose the patient while the procalcitonin is negative. If the procalcitonin is positive, like procalcitonin is 50, the normal value is around 0.5, then if the antibiotic response is appropriate, the previous value will be the half of the previous value in 48 hours. So that means the treatment is effective. So this is also important. If the single procalcitonin is negative, you can change the antibiotic, or you can maybe de-escalate, or maybe you can choose not to give antibiotic accordingly. But if it is positive, the next test, if it is less than the half of the previous value, suppose it was 50 and now it is 22, so means that the antibiotic, whatever you are giving, is definitely working and the patient is getting better. It gives us a speed which we want. Cultures usually takes around 3 days, but procalcitonin gives us speed to treat the severe sepsis patients. The important thing is it is secreted in response to, it's a pro-hormone and secreted in response to the bacterial cell wall synthesis. Suppose we are having some bacteria which is not having cell wall, like chlamydia. So in that case, there won't be any procalcitonin increase. And invasive fungal infection also causes rise in procalcitonin. So this is the only thing which we need to remove. This is a guideline for pneumonia, that if procalcitonin is less than 0.1, it is strongly discouraged to start antibiotic. If it is 0.1 to 0.25 is discouraged, then it is encouraged, and that is, it is strongly encouraged. Okay. Repeat PCT every 2 to 3 days, so that is every 48 hours, and consider stopping antibiotic. There is one more thing which is, I believe that it is costly, but sometimes it is very important to use this test. It is very accurate. So diagnosis of sepsis with biofire. So as we know, the procalcitonin only gives us information whether the patient is having bacterial infection or not. The biofire is multiplex PCR. So it is in the single kit you identify. Suppose this is a list of biofire identification of species, which is for meningitis. So this many number of bacteria, this many number of viruses, and this yeast, so that is fungus, is identified in single code in 1 hour of processing time. Okay, so result is in 1 hour. It is life-saving because time is equal to life. You sometimes, in some cases, when the sepsis is severe, you can't wait for just 3 days for something to grow in the culture. There are total 3 types of panels available. One is pneumonia panel, one is blood culture panel, and the meningitis panel. The meningitis panel is shortest, so I just kept it here. The rest you can find it on internet. The pneumonia panel includes around 40 pathogens, and blood culture panel also includes the same number of pathogens, which includes all the common and all the atypical things. If any, the important thing is, if even one RNA of or DNA of the bacteria is found, okay, or the virus or the fungus is found, it will give us a positive result. One important and very important thing is that for multi-drug resistant cases, for suppose blood culture panel, it also gives OXA48 and NBM gene report. So meropenem sometimes is not working. Empirically, in all severe sepsis cases, we start with meropenem, but this test, if done on time, will give us an information that in your case, whether the bacteria is producing an enzyme which destructs meropenem or not. So OXA48 NBM gene receptors are about that. So whether your ongoing treatment will work or not, you will get report accordingly. The test costs around 17,000 to 22,000, but it is important and life-saving in many cases. Some bacteria and viruses and fungi are so fragile to be grown. So this test is of proven value and we should use it more often. Diagnosis of sepsis, the next thing is do whatever you need to do to diagnose the sepsis, but don't treat the patient without diagnosis. You can have your hypothesis for first 3 days, it is okay, but after that you have to put on all your efforts to diagnose the patient. Without diagnosis, just don't treat the patient. You can send cultures, you can send biofire, you can talk to microbiologist and get smears done, you can get multiple stains done, get whatever radiological imaging required to be done, biochemical test, you can brainstorm with your colleagues. But if you are not able to diagnose the sepsis, please don't treat the sepsis, because you will unnecessarily create bacterial resistance. Never underestimate fungus. This is the take-home message. Fever on higher antibiotics. Okay. And the fever which worsen with steroid. So usually we start with antibiotic, and suppose we consider viral, we give steroids. We have a negative response to both. Like steroids usually improve viral illnesses, including severe life-threatening pneumonia. In COVID also, we have used that. Fever on higher antibiotics and fever which worsen with steroid. Always look for fungus. 1,3-beta-glucan and galactoman, and take some time for to get the report. Okay, from the laboratory. It is commonly done at Ahmedabad, 1,3-beta-glucan specifically. So it takes some time. So give that time and send it early. Don't underestimate fungus. We are encountering it now, significantly more number of cases of fungal pneumonia and systemic candidiasis than any time in previous 4 to 5 years. To diagnose sepsis, you have to be like Sherlock Holmes. You have to be a good clinician and you have to have a mind of a detective. So use your sixth sense, and it is a fun thing to do. Like you will, once you are after it, you like chasing it for the results, and you improve yourself in that process as a clinician and as a intensivist or physician. Fourth point is prove and treat. Do not treat if you can't prove. There is no guesswork allowed as far as sepsis is concerned. Can you just guess that the patient is having myocardial infarction and put a stent in the coronary? No, we have to prove that the patient is having heart ischemia. Similarly, for sepsis, you cannot just give empirically antibiotics. Even empirically, anti-malarials are not to be given as per the guideline of local corporation of Baroda Municipal Corporation. Like malaria, get an MP done, positive, then only treat. Similarly, sepsis also we have to prove and treat. Otherwise, we'll use unnecessarily antibiotics and it will cause problems. Now we have very lucrative media for bacteria to grow in the microbiology lab. Cultures are essential. Take cultures before antibiotics. What happens if you give antibiotic and then take culture? Because the culture bottle, which is a small ecosystem inside, have the bacteria, have WBC count and WBC cells, as well as it has that antibiotic. So the killing of bacteria continues in that also, and ultimately we don't get any growth on the petri dish. So cultures are essential, but send it before you give antibiotic, first dose of antibiotic. There is no compromise. The only proven strategy in sepsis treatment is to prove it with culture. This is specifically for bacterial sepsis, which accounts for around 70% of total sepsis cases. It's the only proven strategy is to prove it by doing culture and then have a report that these antibiotics are going to work with this MIC level. One important thing, the culture is to grow the bacteria is a domain of microbiologist, and I am a clinician. So there is no compromise in taking culture sample. Get your best person, best nursing staff or best phlebotomist to take culture. Usually in any procedure, we do painting, dripping 3 times, but in this procedure, do it 7 times. We don't want any contamination. Take high volume of culture, 10 to 20 ml, take it in a bactet and get the sensitivity through Vitek, and always take 2 samples of culture. You have to label from where you are taking culture. Suppose you are taking in anticubital vein, mention that these 2 sets are from anticubital vein. Suppose you have a central line which is more than 48 hours old, then you have to mention that this is from the femoral central lines lumen, and the other you have to take from from the peripheral prick, and you have to match the growth of both the samples. Sometimes in laboratory, one sample from the same person is growing some bacteria, another is not. You need to identify from where this infection came, whether it is from the central line or dialysis catheter, or whether it is a peripheral blood which is growing bacteria. Whenever you have central line, please send culture from the central line also, and you have to send a separate sample from the peripheral line as well. There is no compromise in that. If you are not having any growth in the culture, suppose you are not sending culture only, then what is the endpoint of antibiotic treatment? I am just trying to confirm you that convince you that for how many days you are going to continue antibiotic. Is it 7 days, 14 days? It is additional financial burden to the patients and the family in an economy like India. And suppose we don't consider money, someone somewhere is paying for the patient. Take help of the microbiologist. It's your best friend when you are dealing with bacterial sepsis. Positive culture and you are giving sensitive antibiotics is a reason for very nice sleep for an intensivist, because it's going to work. Okay, so your patient is going to go better. You encounter less complications when you properly diagnose and you are treating the patient. Your patients and relatives will understand sepsis better with culture, because you have a report which is printed. They can go to the report for second opinion, and they can understand it that these many drugs are working and these many drugs are not working. If the IV antibiotics required for a longer duration of time, they will understand. Culture reports are never costly because it is less than 1 day dose of a cheapest antibiotic, because the only thing is that it is to be done at proper time and proper method in a proper laboratory and should be reported properly. Suppose sometimes we encounter that there is nothing is growing in culture, the why to send. No growth in culture is not the problem of the bacteria. Bacteria doesn't understand. Bacteria doesn't have that discrimination that I'll grow in this and I'll not grow in this. There is something wrong in your part. You have not taken sample properly. You have taken it with antibiotic. The transit is a problem or the laboratory is a problem. Always talk to the microbiologist. When the procalcitonin is high, the patient is throwing high grade fever spike and chills, the culture has to grow something, has to grow. Most important lab marker is cultures. Get culture at right time, right method. So this is what the take home message from this slide. It improves sepsis and saves life. More culture means more survival. This is my personal opinion. Antibiotics and ICU should be always culture driven and stewardship driven, not experience based. Prescribe antibiotics without cultures. It's like driving blindfolded. Fifth, early antibiotics. How early and which one? Choosing correct weapon is only possible if we know what bacteria we are treating with. At least we have an estimation that what we are thinking of. So basically we have to have a hypothesis like we have for any disease, that which organ is involved in this sepsis and which comorbidities the patient is having. Suppose a diabetic patient has more chances of urinary tract infection. So it is, we all know this. So this is as simple as that. Survival sepsis guideline says that in 1 hour you have to give antibiotic, but the correct answer is we have to hit hard, hit fast, and hit often. So the correct answer, how early the antibiotic should be given, is as soon as possible. Like if you are thinking that the patient should receive a meropenem because the patient is having organ dysfunction with possible urosepsis because outside urinary tract infection was positive a few days back and patient has not taken any treatment. If you have antibiotic with you, should not wait even for 2 minutes. Just administer the loading dose of antibiotic straight away. Okay. Which antibiotic to be used? In nutshell, this is a whole topic in itself, but it depends on the organ which you want to target. Suppose you are dealing with meningitis, bacterial meningitis, then meropenem works best. But even ceftriaxone is having more CSF penetration, and in fact it performs better than its superior cefoperazone sulbactam as a because the ceftriaxone CSF penetration is better. Lungs, levoflox works better because linezolid's lung penetration is less than the levoflox. In kidneys, macrolide doesn't like kidney. They don't have any role in urinary tract infection. Macrolides doesn't like azithromycin, doesn't go below diaphragm. Liver, first see the things which has to be, suppose we are treating some infection in liver, first see that the antibiotics which you are giving is not toxic to the liver, like linezolid is toxic to the liver and should not have metabolism in liver. Kidney, always differentiate a nephrotoxic drug which is to be avoided in kidney dysfunction versus the drug which is not doing any harm to the kidney, just is elimination is through kidney, the dose adjustment is required. All the antibiotics are dose adjustment required in compromised renal situation, but all are not nephrotoxic. So the difference you have to keep in mind. Whatever antibiotic you are prescribing, trust them. No frequent changes antibiotic without culture report. Give 3 days time for antibiotics to work. Suppose you start with ceftriaxone, 2 days, patient is having fever and you change over to meropenem and the patient improves. There is no fever spike after first dose of meropenem. Definitely it's not the meropenem working, it's the previous antibiotic which has given the effect because it was there in the blood already. Another thing, this is a secret which no one says, that meropenem has a side effect of mild bone marrow suppressive effect. So suppose you are giving augmentin, but there is no total count decrease, but you give 2 doses of meropenem and the total count decreases from around 13,000 to 10,000. You feel that sepsis is improving? No, because this is slight mild bone marrow depression effect of the meropenem, that is leukopenic effect. Meropenem is not oral meropenem. It is a type of cephalosporin group of drug and not to be used. Lactate in sepsis. Lactate is a marker of perfusion, measure the effectiveness of the treatment, and most important marker. Like lactate is an emergency. Like when the lactate is not proper, you have to act now. Okay, otherwise you will lose the patient. And in most of the cases, and the lactate is inappropriate, you have to deal with proper fluid management. As we know, the lactate is end product of an unhealthy metabolism that is most commonly with improper perfusion. We don't routinely check lactate, do we? But it is so easy to check lactate, because this lactate which we are talking about is, first of all, the lactate which is mentioned in definition of sepsis, that is arterial lactate. We are not talking about venous lactate. It is of no value. We are only talking about arterial lactate. Okay, so we don't routinely check, but it is very easy, because we can have ABG in all critical patient, and the ABG report includes lactate if we ask for it. Okay, so lactate is the only specific way to inform prognosis. Suppose the patient comes, fever, etc., blah blah blah, clinical things are okay, but if lactate is more than 4, you can tell the relative the mortality and morbidity associated with it, because there is significant data that if lactate is more than 2, it is septic shock, and if it is lactate more than 4, it includes significantly mortality and morbidity burden at the time of admission. So we have to get it done in first hour of sepsis and repeat after 24 hours to see the improvement. We estimate lactate early, treat early leads to less complication. Patient pathology is reverting back to the physiology when lactate improves. This is very important. This is the paper for the same. Lactate as a predictor of mortality in emergency department and patient with infection. When the lactate increases, this is just one slide to summarize. Unnecessarily high vasopressors causes severe vasoconstriction and impaired cellular metabolism, because there is no proper blood flow at the periphery, at the capillary level, and that's why high lactate. Severe peripheral vasoconstriction is the same thing. Hypoperfusion may be because of dehydration or gangrene or something. Tissue hypoxia because of low oxygen. Krebs cycle shift through glycolysis and produces lactate whenever there is not enough ATP generation through Krebs cycle. End product of many metabolism is lactate, and tissue in presence of tissue hypoperfusion, lactate is not converted to bicarbonate, and then it causes increase in lactate level. The normal lactate value is 0.7 in arterial sample. If we miss lactate, the only thing which can diagnose your patient is autopsy. So never ever miss lactate in first hour, and we are talking about arterial lactate. Don't send venous sample for lactate. Vasopressors in sepsis. We must know when to use your Brahmastra, what fluid challenge we are supposed to offer, and when at right time in right way we are supposed to start vasopressors, because it is very important. Which vasopressors you will choose? Dopamine, noradrenaline, vasopressin, dobutamine, levosimendan, adrenaline. Just say no to dopamine. Okay, no one is going to pass you critical care exam if we say that in my ICU I'm going to use dopamine as vasopressor in sepsis. It is not recommended now. Good ICU doesn't have dopamine in their stock. Only thing which is to be used in sepsis is noradrenaline. Remember, vasopressors work best early. Vasopressors work best together. Start vasopressin, add on to noradrenaline as fast as you can, so that you are not late. In any cost, you want to give fluid, you give fluid. You want to give antibiotic, give antibiotic. You want to do ECMO, do ECMO. You want to give vasopressors, start noradrenaline. But please maintain the internal perfusion of the patient and keep lactate in the normal value always. Do not waste time in fluid challenge. Start as soon as possible. That is, start noradrenaline as soon as possible. Then taper off fast if your patient improves. That will prevent organ damage. And touch your patient. If the patient is cold, start noradrenaline. Life-threatening, the most life-saving drug can be life-threatening drug as well. So use it very judicially. You are not measuring blood pressure properly, and the normal sphygmomanometer is not effective when the patient's blood pressure is low and you are bombarding the patient with multiple vasopressors. Severe vasoconstriction lead to cold extremities, lead to improper perfusion, lead to stasis, lead to lactic acidosis. Lactic acidosis causes fall in pH, that is fall in BP. Fall in BP is more vasopressors that you increase, then severe vasoconstriction. So you are in this vicious cycle. Always give vasopressors through a proper central line. Always give noradrenaline that is more than 5 ml per hour, 5 ml per hour through central line. This is required. When you are not able to measure BP, how you are going to titrate the noradrenaline dose? You are basically playing blindfolded. So it is not to be done. But we have to keep aiming. We have to keep aiming for a normal blood pressure. So what should we do? You have to take an arterial line if the noradrenaline is more than 5 ml per hour and your blood pressure is not normal. It is significantly important to have arterial line. This is arterial trace. Okay. Is arterial tracing when the patient is sick, because there is nothing like sudden arrest in ICU. You have to know when the patient is going to have arrest. Before that, you need proper lactate monitoring. You have to have proper blood pressure on your monitor with each and every heartbeat. So at the moment when hypotension happens, you can act, and you will have 3 to 4 minutes to act during that time period, and you can save life. It's a game changer basically. Benefits of arterial line: prevents organ damage, appropriate vasopressure titration, pulse pressure variation is gold standard for fluid responsiveness. Cardiac output estimation you can do easily in pulseless VT or VT with pulse. You can identify, and the algorithm totally changes. Can have time to treat the hypotension. Suppose hypotension happens at the initiation of dialysis. You start with fluid, and suppose it happens in between the dialysis, then the management is different. There is no side effect of proper arterial line, which is taken through USG guidance. It is easy and can be, it is having a steep learning curve. Point number 8, fluids in sepsis. If you miss fluid management, rest of the things will not help. You lose. I have only one thing to say in this whole topic. Give 1.5 liters of fluid, that is 30 ml per kg body weight, which is according to the International Guideline of Surviving Sepsis guideline. Low blood pressure, septic shock, high lactate septic shock, both things can be treated with fluid. Only normal saline is to be used, because if we give Ringer's lactate and the tissue perfusion is not proper, the lactate cannot be converted to bicarbonate at a cellular level and in the liver, so that it causes higher lactic acidosis. So what is the end point of fluid challenge? That is either 1.5 liters are over, or the lactate is normal, or the BP is normal. Okay. 1.5 liter is 3 pint over first hour of sepsis management. This is what the fluid is required. If you have a patient who is having previous history of cardiac issue, put a probe, take a USG probe, put a probe, and now USG probe is new stethoscope. See the IVC, If it is congested, don't give fluid. There is no requirement of fluid. But if it is not, then you have to give fluid, 1.5 liter. This is a very small algorithm for the same. I'll just go into the detail because we are running little out of time. Empirical fluid load 30 ml per kg if mean BP is less than 65 and lactate is more than 4. Ultrasonographic, that is USS assessment of IVC. If IVC collapse, give fluid again. Assess IVC, give fluid again. So this is in addition to this 30 ml per kg body weight, 30 ml per kg body weight of fluid bolus. Okay. If the IVC assessment is okay, static, that is more than 2 centimeters IVC diameter, use B lines. If there is no B lines, that is no fluid overload, and the echo is normal, still give fluids till the B lines come. So properly give fluids to the patient, properly load the patient with proper fluid volume. Okay. Only if the echo is showing hypodynamic, low EF, only use vasopressor with CVP quantity. Antibiotic dosing frequency, how often leads to how well. Do we have any interaction or question or something? Yeah, I'll continue. So
we ended up building was basically a petri dish.
Can you listen to the video's audio? Okay, so I'll only explain. Just a minute. I'll just mute this video and explain. So this is an experiment done at Harvard Medical College. They have a huge petri dish, which is having 2 feet by 4 feet of diameters. And in that they have sections, embedded sections in it. And they have different concentration of antibiotic. The 0 is there is no antibiotic in this region. Then there is 1. That means there is antibiotic up to 1 point, like grade 1. Then they have antibiotic up to grade 10, grade 100, and grade 1000. So suppose we have ceftriaxone here, cefoperazone sulbactam, piperacillin tazobactam, and in center we have meropenem. Suppose just assume this, okay? And then the bacterial growth is allowed only in the direction of the growth, okay? So in the first part where there is no antibiotic, the bacteria is going to grow. We want bacteria to grow in that part, okay? Then they encounter a part where there is antibiotic, okay? Sorry. Then they reach to a part when there is antibiotic. Just a minute. So then they reach a part when there is an antibiotic up to concentration of 1. Some bacteria develop resistance to that antibiotic and they start to grow, and then they predominate and fills the complete area, okay, of the antibiotic zone. Then they reach and also multiply in the antibiotic which is of up to grade 10. Can you see this one spot? And then that bacteria only grow, the others stop. They are spotting again at different time zones. Then they reach the antibiotic worth concentration of 1, 10, and 100. And ultimately, they reach the antibiotic which is the 1000 concentration as compared to the 1 concentration here. And then also they have a spot and then they grow. Okay, I'll give you a challenge. Suppose we are in a room, 100 people. Suppose 100 people are in a room where someone releases toxic gas. How much that gas is toxic and intended for killing everybody. How many of us will survive? No one will survive. But I give you a challenge that if we are bacteria, one of us will survive and they'll grow in that poisonous gas. So these bacteria are that smart. Don't underestimate and don't give that chance. The most important thing regarding this whole thing that it only took 4 hours to the whole thing to complete. So the antibiotic resistance happens so fast that from 1 concentration to 1000 concentration, the bacteria gained the capacity of growing in spite of the antibiotic concentration in just 4 to 6 hours. This is very important. Don't give subclinical doses that doesn't kill the bugs. Okay, always gives good dose and give them to chance. Don't give them chance to survive in presence of drugs that will cause resistance. Give right dose of antibiotics. Always give as frequent as possible. Like ceftriaxone dosing frequency is 8 hourly. There should be a minimum serum concentration in the of the antibiotic in the blood at all given time. Okay, the dose is 3 grams per day for 60 kg person, not less than that. There are 2 types of antibiotic. One is time dependent, in that the more time the antibiotic is above the MIC level. I think the audience know what is the MIC actually. That is minimum inhibitory concentration above which the bacteria is going to die. So the more amount of time the antibiotic level is above the MIC line, the bacteria are going to die. So that is time-dependent antibiotic. Meropenem, colistin, all are time-dependent antibiotics. So you have to give it over a prolonged infusion. By concentration-dependent antibiotic like macrolide, 500 milligram azithromycin once a day, not 250 BD, because you have to give it at a higher concentration. More is the concentration, more is the killing. More the prolonged the infusion is, more is the killing. So this is basically how the antibiotic works. Okay, prolonged effect in concentration dependent antibiotic doesn't work. So in this group we have fluoroquinolones and macrolides. Here we have carbapenems, most important. Meropenem gives over 3 hours infusion. Colistin is given over 3 to 4 hours infusion every single dose. Failing to do so is we are using a very important of our weapon with less effectiveness. Don't do that. Always give meropenem over a prolonged infusion. Antibiotic resistance, this is our last topic and I have 3 minutes to speak on this. We have enough time. So we are already fighting a lost battle. If you see the world, antibiotic perspective, nothing remains. Like you see in movies that post-apocalyptic world, post-apocalyptic saga, like we are just fighting for survival. It's like that. We don't have any antibiotic. I don't have words to explain what we have done by misusing the antibiotic in previous 50 years. The world has basically came to an end. Microbes are more smarter than us. See, we had dinosaurs. Okay, they are wiped off now. Then we have that Egyptian and Harappan cultures. They are wiped off again. Like we don't know what happened to them. But at that time also, with dinosaurs also, E. coli and Klebsiella were there. And in this Harappan culture also, the bacteria were there. So they are the evaluation works on survival of the fittest, and they are more fit than us to survive. That's why they are there. Never underestimate these small microbes. We are not able to see them, but they are very, very powerful. एक दिन हम रहेंगे या नहीं रहेंगे, but ये लोग तो होंगे ही होंगे. So we have to use our armamentarium against them very, very judicially. We don't have much antibiotic. We are losing the battle. We don't have any armor. We are now having community acquired XDR, pan drug resistant bacteria, community acquired. Every single day, 2 or 3 patients in ICU. We don't have anything to give. Will you see your COVID patient without mask and PPE? This is happening to them. We are just letting them go, just because letting them die, because we don't have any antibiotic to treat. Even combination sometimes doesn't work. See, this is timeline of how the antibiotics were invented. Okay, so the one important thing I find out, we invented tetracycline after 10 years of research in 1950, but the bacteria developed resistance against tetracycline in just 9 years. Okay, vancomycin we invented in 1972. Vancomycin resistant enterococcus just in 1988. The bacteria found out how to overcome this drug. Okay, so suppose Levoflox, so it was in the same year, Levoflox 1996 and Levoflox resistant pneumococcus in 1996 only. You can see the duration is getting smaller. Linezolid 2000, 2001, linezolid resistant step. See the gap here and gap here. Similarly, in 2004, we have seen pan drug resistant Acinetobacter and Pseudomonas, and now it's a common case in each and every ICU. In 1983 to 87, we have 60 new drugs like this one identified, and we invented them. Okay, now we inventing less and less drugs. Since suppose we see 2008 to 2011, only new drug we are able to identify. All the previous drugs we are losing, bacteria are getting resistant to them, and we are not able to develop new drugs. So it is typically for a dead end. Okay, this is my last slide. If time permits, what are the poor prognostic signs? It is not a part of 10 things which are important in sepsis. Like it is not a part of 10 things which I want to discuss. But suppose you are treating a sepsis patient, recurrent hypoglycemia, lactate more than 10, fever on higher antibiotics, think of fungal infection, persistent altered mental status. There is a poor prognostic sign if your doctor is not able to diagnose the source of sepsis. It's poor prognostic sign if relative doesn't have trust in treating team. So this is my personal belief. Here we conclude the 10 things commonly missed while treating sepsis.
Thank you, Dr. Udgit. You can stop the screen sharing now so we can have a discussion.
Yes, sir.
Not enough words to describe your talk. Excellent in every way you think about. Like the content itself was great. I would say each and every 10 point, I was debating in my mind that which is the most important. And I thought that each and every point you have emphasized so well. That very excellent. I mean, good messages have been given by your very comprehensive talk. So thank you so much for that. There are some questions in the chat box. Let us take them one by one. Dr. Manoj Yadav, who is a pulmonologist, is asking, in most ICU, he has a comment actually, in most ICU, despite a normal procalcitonin tested repeatedly, antibiotics are changed or escalated. So what is the rationale for this? Other question from him is, how routinely are markers of immune deficiency done in ICU, especially in or not responding to ongoing treatment, like CD4 or immunoglobulins or AN? There are two questions.
Yes, sir. So first we'll take the first question. In most ICU, despite normal procalcitonin tested repeatedly, antibiotics are changed or escalated. Okay. So there is no rationale for the same unless you have positive culture. culture is above procalcitonin. Like if procalcitonin is negative, but you have positive culture, you have to escalate antibiotic. In most ICU, I would say have an estimation of that ICU flora. Suppose the ICU flora is having a multi-drug resistant bug, which is only sensitive to meropenem. It is justified to start meropenem because patient will be in that environment. So it's going to pick up that bug, and to prevent that prophylactically, it is important to give that antibiotic. For all intensivists, including me, the message is keep your ICU as clean as possible, cycle your antibiotic, have a data of last 50 or 60 cultures, and see if your if your Klebsiella is sensitive also to cefoperazone sulbactam, just give cefoperazone sulbactam as your empiric treatment and don't give meropenem as your empiric treatment. But if not the case, then you have to give. Antibiotics are to be changed and cycled if you have any evidence. Without evidence, don't go for it. It is not a rational. Fever, yes, fever can be an early sign, and if you don't want to miss, you can escalate. But always send a culture. Have a backup with you that I have sent culture. It will grow something. If it doesn't grow something, then we can escalate. If it de-escalate, if it grows something, then we can change antibiotic according to that. We have to sometimes act fast. It is not no to change the antibiotics, but as sir rightly said, you have to do it with proper evidence. The next question is, what is the role of steroid timing and choice in sepsis? Bacterial sepsis, we have to avoid steroids. Fungal sepsis, we have to avoid steroids. But in viral sepsis, because it's only inflammatory related, sometimes the immunity related, we have to blunt immunity in severe cases, and we can use the steroids if PCT is negative, if cultures are not doing anything. And we can use steroids in refractory hypotensive shock because of adrenaline insufficiency. We can use steroids with 50 milligram TDS. There is no major drawback of using steroids if it is life-saving, or like if patient is having severe organ dysfunction or hypotension for 1 day or a short course of steroid or 3 days of dexamethasone or 1 day of dexamethasone. If it changes the patient's clinical scenario, then you can stop. Even in bacterial sepsis, we can give a small dose of steroid and see. Role of steroids, timing and choice of sepsis, like it is most of the time hydrocortisone above anything else because it is short acting, and we can use hydrocortisone. In viral sepsis, we are using steroids more often than bacterial or fungal. I think that summarizes. It's a long debatable question, so we'll take another question.
Dr. Udgit, have you addressed this question? How routinely are markers of immune deficiency done?
Just a minute, sir. I think I missed that.
Yeah, you missed that.
How
And then Dr.
deficiency
Jitendra Mistry wants to comment on something. So after your answer to this question, Dr. Jitendra Mistry wants to have a comment. So please go ahead with this answer. Yeah.
Just a minute. I'll just take this question. I missed it because in the chat section it just scrolled up.
Yes.
How routinely the markers of immune deficiency done in ICU? It's not commonly done. We have to suspect it on time and do it when the ongoing treatment is not responding to anything. So immune deficiency is common in post-COVID era specifically because we have used lots and lots of steroids, and it has to be done like CD4 immunoglobulins and ANA. I agree to what sir is saying.
Right. Another question probably we have not taken is role of PCT in subclinical sepsis.
Yes, role of PCT in subclinical sepsis. If the sepsis is subclinical, the PCT will be negative. So if it is systemic sepsis, the bacteria are synthesizing cell wall, not in a closed cavity, not in an abscess, not in a localized area, like not inside the lung or liver. It is in blood and spreading everywhere. Then only the PCT will come positive. Otherwise, it won't come positive. So if PCT is negative, you can have subclinical sepsis.
Yeah.
So sepsis is like sepsis. There is no SARS. So SARS was subclinical sepsis. It is removed from the definition. There are only 3 things. Point number 1, which we discussed in my lecture, that sepsis is only presence of infection. And you can go back to that and see the definition that there is no subclinical sepsis. Sepsis is like what we can see and diagnose.
Yeah. Now, Dr. Jitendra Mistry, you wanted to make a comment. He is emphasizing on the source of sepsis. Dr. Jitendra?
Sir, good morning. Good morning, everyone. Dr. Udgit, this is a very positive, constructive criticism. My take on the sepsis is that sepsis should never be taken as a diagnosis rather than a manifestation. In practice, we very routinely see whenever something goes wrong, immediately the attending doctor will say that it seems like there is a sepsis, and we upscale the antibiotics. But the enough emphasis is never made on making the diagnosis or etiology. I'm not talking about in terms of organism. I'm talking about the source of organism. So if there is a collection or there is a platelet count low, and immediately we say that there is a sepsis and we upscale the antibiotic, but we don't see at the etiology, and if we don't treat the etiology, just start the antibiotics, even if the culture based antibiotic, it may not work. So emphasis should be made on the etiology and source of the infection rather than the only type of the infection and antibiotic. I mean, I would love to have your comment.
Yeah, this is absolutely right. Suppose the line we already discussed in point number 3, that is diagnosing sepsis, that if the line is infected, you have to remove the line, you have to send the line, you have to send the culture from the line. If your OT is infected, you have to clean the OT, you have to clean the air duct. If your beds are infected, you have to clean the beds. If your suction apparatus are not proper, then you are not going to achieve anything good by treating the patient in sepsis, because it's going to give the bacterial load again and again. This has to be done. There is no doubt about it, and very rightly you have pointed this out. I'll just take liberty to tell one thing, that also nothing to be assumed in sepsis. You have to confirm that this was the source, the line was the source, and I removed it. The operation theater was the source, and I cleaned it, and the suction apparatus was the source, and I cleaned it and cultured it again, and there is no further growth, and now the patients are safe. So this is how it has to be.
So I think that rather than saying that there is a sepsis, we should add something along with the making the diagnosis of sepsis, that what is the source and from where it is coming.
Yeah, so
just saying the sepsis shouldn't make the end.
Yeah, suppose you have 3 positive cultures of multi-drug resistant Klebsiella, you send culture from everywhere, from the nurse's hands to the suction apparatus, to the operation theater, to the ICU door handle, to ICU CUG mobile phone, and find out. It will grow from multiple places in the ICU. Acinetobacter is the most common in these type of cases, and you can clean everything, the stethoscope and IV stand and everything. So that has to be done. There is no option. Basically, it's a in-house microbiologist domain, but definitely a clinician is also has to be vigilant for the same.
Right.
Thank you, Dr. Jitendra, for that interaction, and I think the point is well taken. There are no more comments in the chat box, so we can end the session. But before we end the session, I must reiterate that it was an excellent talk, and you gave very hard-hitting messages. Particularly, what I liked was about importance of cultures and importance of choosing the right antibiotic and using the antibiotics judiciously, with having a stewardship policy in all the clinics. I mean, that was something very wonderful that we all needed to re-emphasize. And before we end, I also want to express my thanks and gratitude to Dr. Kiran Dalal, who actually made this happen. So thank you, Dr. Kiran, if you are around, and we end the session here. And we meet next Saturday again, and we'll have an excellent talk with Dr. Alok Gupta, who is a pediatrician but an environmental activist, and we'll have some wonderful information about what role doctors can play in this environment challenges that we are facing. So thank you all. Thank you, Dr. Udgit, once more, and we look forward to more talks from you in future in Saturday Club. Thank you so much for accepting our invitation. Thank you.
We'll be glad to